Hello, my name is Ariel Charles, and I'm currently a PGY1 pharmacy resident at Erlanger Health System in Chattanooga, Tennessee. Today I'll be presenting my research on the effectiveness of an antibiotic treatment protocol in the management of community-acquired pneumonia in pediatric patients at an academic pediatric hospital. The authors of this investigation currently have no disclosures that they would like to communicate. The Pediatric Infectious Disease Society and the Infectious Disease Society of America recommend for the treatment of community-acquired pneumonia that if a patient is fully immunized, they receive amoxicillin or ampicillin. If they are not fully immunized, they receive cefdinir or ceftriaxone, and if they have a severe allergy to penicillins, they receive clindamycin. Despite this recommendation, many patients who are fully immunized are given some type of alternative antibiotic. Evidence has shown that utilizing a protocol increases the adherence to guideline recommended treatment. This investigation took place at Children's Hospital at Erlanger. It is the area's only comprehensive regional pediatric center. It has a level 4 neonatal intensive care unit and is the region's only teaching children's hospital. It also has the region's only pediatric emergency department. The purpose of this investigation was to evaluate appropriate antibiotic selection for pediatric community-acquired pneumonia, or CAP patients, after the implementation of a guideline-driven treatment protocol. The primary outcome for this study was to compare antibiotic therapy selection in pediatric patients with suspected CAP before and after implementation of a protocol. The secondary outcomes for this investigation include the assessment of the occurrence of appropriate treatment selection and dosing, penicillin allergies, immunization status, and average duration of therapy. This was a retrospective, institutional review board approved single-centered study that looked at 2 respiratory seasons, from October 2018 to February 2019 and October 2019 to February 2020. In October of 2019, a community-acquired pneumonia order panel was implemented, and data was collected for both respiratory seasons using chart review. Patients were included in the study if they had received antibiotics or a prescription for outpatient antibiotics in the emergency department and were greater than 60 days old or less than 18 years old. Patients were excluded from the study if they had immunodeficiency, an increased risk of aspiration pneumonia, cancer, known lung disease, a prior or current tracheostomy, or a lung abscess or empyema. A chi-square test and a Mann-Whitney U test were used for a statistical analysis. In order to meet an 80% power, there had to be 55 patients in each group of the study. Patient demographics that were collected during this investigation included gender, age, whether or not the patient had been fully immunized for their age group, whether or not the patient had any allergies to penicillins, and if the patient had used antibiotics 14 days or less prior to their visit at the emergency department. For the primary outcome of this investigation, there was an increase in the amount of amoxicillin used in the post-protocol group. There was also a decrease in the amount of cephalosporins used, as well as azithromycin used in the post-protocol group. Both amoxicillin increases and azithromycin decreases were found to be statistically significant. Appropriate antibiotic selection increased to 71.8% in the post-protocol group and was statistically significant. There was also a statistically significant increase in the amount of patients considered fully immunized. 14-day readmissions, as well as the average duration of therapy, remained very similar between the pre- and post-protocol group. We found a statistically significant increase in amoxicillin use, as well as a statistically significant increase in appropriate antibiotic selection. There was a statistically significant decrease in azithromycin use, and clinically significant decreases in cephalosporin usage. The limitations of this investigation include that it was a single center study and limited to 2 respiratory seasons. No sputum culture data was collected, and the accuracy of diagnosis in regards to whether or not the infection was viral or bacterial was not evaluated. 14-day readmissions were limited to this single center and did not include any outpatient clinic visits. The strengths of this study include the large sample size and that it did meet 80% power. Evidence-based recommendations were also included in this investigation. In conclusion, the introduction of an order panel was effective in helping to guide appropriate antibiotic selection for community-acquired pneumonia treatment. There were statistically significant increases in guideline-recommended therapy for fully immunized patients and clinically relevant decreases in cephalosporin and macrolide use. For the next step of this project, the data collected will be used to formulate a quality improvement project for the hospital this spring. Future studies should consider the accuracy of diagnosis and the role of antibiotics in cases where the patient had a positive viral panel. These are my acknowledgments. For my self-assessment question, what antibiotic is indicated for suspected CAP in fully immunized pediatric patients? The correct answer is amoxicillin. Thank you for your time. If you have any questions, please do not hesitate to email me.